So we add in the 2 decubes plus this decube, and the post-evac is done only if the radiologist requests it. Now, the right and left lateral decube, you will find those on page 520 and 521. So what I'm going to tell you applies to both because they're the same exact thing, other than the patient lying on the right side versus their left side. So for the decubes, we start off with those. Notice we use a 14 by 17, however would work for the patient. So this particular patient would fit on one 14 by 17 lengthwise, and that's how that image receptor is set to the patient. If your patient required two 14 by 17s crosswise, then you would have to take two 14 by 17s crosswise for the decubitous view. The technique for this is 90 kVp at 3.3 mass, because it's double contrast. I mean, there's not only barium, but there's also air. So the patient would lie on their right side. You have a horizontal beam because it's decubitous, and you're also looking for an air fluid level. Your central ray is at the level of iliac crest and midline. And in this particular view, what you're trying to demonstrate is the descending colon is going to be up. So you've got the descending colon up here. So you've got left splenic flexure, descending colon all the way down to sigmoid and rectum. But a lot of times you'll actually find polyps in the ascending and descending. So on the right lateral decube, you're looking for polyps in the descending colon. Notice you can see the air fluid levels. You can see the barium right here because fluid falls and air rises. Okay, so you have to demonstrate the entire large intestine. You want no rotation of the patient, and you want optimal exposure factors. After you complete the right lateral decube, you would do a left lateral decubitus. Again, patient on their left side, horizontal beam, and the IR oriented to however your patient's body habitus would require, whether it's one lengthwise or two crosswise. Central ray is still iliac crest and midline. And just like with most decubes, notice that we're marking side up. So on the left lateral decube, you use right marker. On the right lateral decube, you're using left marker. So decubitus is called by the side down, but marked by the side up. And the technique for this is the same as the right lateral decube, 90 kVp at 3.3 mass. And again, you have to demonstrate the entire large intestine. You want to make sure there's no rotation. And now the ascending colon is up. This is right hepatic flexure, ascending colon. So you want to make sure that the radiologist is actually looking in this area for any polyps that might be present for the patient. Not that they're not looking everywhere else, but polyps tend to be in the ascending and descending. So these decubes are vital to make sure that you get good air fluid levels in there and that you don't clip off any portion of the entire large intestine in either image. So we do our decubes and we go right into our normal routine. Our AP axial butterfly, again, which is on page 523. You have a 30 to 40 degree cephalic angle on the central ray. Central ray is 2 inches below ACIS and midline. And our technique on this, since it's double, is 100 kVp at 3.3 mass. And remember, the AP axial butterfly straightens out the sigmoid colon. That's the whole reason that we do this particular image. After AP axial, we go to AP. And the AP for the double contrast is on page 515. The technique for this is 90 kVp at 2 mass, and the central ray is iliac crest and midline. And again, this is a picture of a single contrast BE, but you would do the same exact image for a double contrast. You would just see a lot more air in here and only the outline of the intestine. After AP, we do our oblique, our RPO and LPO. Remember that these tend to show the side up flexure open, and these are on page 518. The patient is in a 35 to 45 degree oblique. Remember, we have to fix this to read 45. Central ray, the level of the iliac crest, and 1 inch to the side up. So in this particular LPO, it would be 1 inch towards the right side. In the RPO, it's 1 inch up from xiphoid towards the left side. So at the iliac crest and 1 inch to the upside. And whatever oblique this is, so if this is LPO, the side up flexure is open. So the right hepatic flexure is open for this one. This one would demonstrate the left splenic flexure. And again, your technique is 90 kVp at 2 Mass for your RPO and then your LPO. Like I said, it opens the side that's up. So this is your LPO and it opens the right hepatic flexure. This is your RPO and it opens the left splenic flexure. After that, we do our left lateral, and this is on page 519. So this is the bigger picture here. We do the left lateral. The technique on this is 90 kVp at 2 Mass, and the central ray is at ACES and mid-coronal. Remember, this is to demonstrate the lateral rectum. So it's at ACES, not crest, and mid-axillary. And the is 90 kVp at 2 Mass. And then when we look at the lateral rectum, at this point, the enema tip would still be in the patient. You can see the retention cuff full of air, the tip itself. You can make out the sacrum and the coccyx. And here we have the rectum of the patient. After we do that and we check those images with the radiologist or the lead tech or whoever's in charge, check all of those images. If everything is good and nothing needs repeating, then the next image you would do for a double contrast barium enema is a ventral decubitus. And this is also on page 519, but it is this little picture right here. So we know that decubitus implies a horizontal beam, and we're looking for air fluid levels. And ventral is the anterior surface. So she is in a ventral decube, meaning she's lying on her stomach and the beam is coming in horizontal. Okay, so for this ventral decube, I can tell you that she is lying on her stomach and her right side is against the IR. So you're going to mark it with a right marker. If her left side was against the IR, you would use your left marker. Central ray for this is just like it was for the lateral. That was ACES and mid-axillary. Same thing here. It's at the level of the ACES and mid-axillary. So when you reach under the patient right here, your ACES tends to jut out. So this would actually stick out, and when you place your hand under there, you would definitely feel the patient's ACES. And then you place this crosshair at mid-axillary. Okay, now when you do this ventral decube, you have the patient lying, you have the beam horizontal, you're centered to ACES and mid-coronal. All right, and what you do with that particular image is this is actually going to show an air fluid level in the rectum. So right before you actually expose the image, you're going to give the patient 2 puffs of air. You're going to deflate the retention cuff and slide that tip out, and then run and make your exposure. So the patient has no more tip in them. You want them to hold on to the air that they have. And what this does is give you an air fluid level of the rectum. And it's also the only image to show no foreign body in the rectum, because every other image would have the enema tip. This is the only one that will not have the enema tip in it. So if there was anything going on in the patient's rectum, whether they had a rectocele or some kind of mass or some kind of pathology, a polyp possibly, you would demonstrate it on this because of the air fluid level and no foreign body in the rectum because there is no tip. Once that image comes out, you check that. If there's nothing else needed, then when that image comes out, you would take the patient into the restroom. You would allow them to sit and empty as much as they can. Now at this point, there's not a whole lot of barium in there, but there probably is quite a bit of air. So the patient is probably going to be sitting in the restroom, emptying the air. You're going to hear a lot of passing gas, but that's okay because we want them to empty as much as they can. We are cleaning up the room, and only if it's requested do we do a post-evac. With a double contrast, it's not typically not requested, but depending on what's going on with the patient, the radiologist may ask for one. If they do, then we set them up, just like we did for our post-evac, which was found on page 522. We would just lay the patient on their back. We would set the control panel at 90 kVp at 2 mass, center iliac crest and midline, and take an image to show how the large intestine actually emptied the barium and the air that was present. But typically this is not a routine image, only by request. All right, and that concludes the double contrast enema. That is a very common exam done. I can tell you it is not comfortable for the patient whatsoever. The prep is miserable. The exam itself is miserable because the patient is forced to be filled with air in their intestine, and they're not really, it's not really encouraged that they pass gas to get rid of that. So imagine having a bunch of gas in your intestine and not being able to pass it. Someone telling you, nope, don't get rid of it, hold on to that, let me pump more. Your patients are typically not loving this exam at all. The next exam we're going to talk about, so we've talked about a single, we've talked about the double. Now we're going to talk about evacuative proctography, or sometimes it's referred to as a defecacography. That's a mouthful. Defecacography, this is, if you turn back to page 508, this is in your book, okay? Evacuative proctography, or an evacuative proctogram, or they'll call it a defecagram. All right, defecacography is a functional study of the anus and rectum during the evacuation and rest phase of defecation. Okay, so on 508, you'll see that a third less common type of radiographic study involving the lower gastrointestinal tract is evacuative proctography, sometimes called defecacography. The purpose and the definition of this is that it's a functional study of the anus and rectum conducted during the evacuation and rest phase of defecation. So you're actually watching the patient have a bowel movement of barium. Some of the indications for this exam would be a rectocele, and a rectocele is basically a blind pouch of the rectum caused by a weakening of the anterior or posterior wall. It literally is like a big diverticulum in the rectum. So you've got that outpouching, and what can happen is you can retain fecal material in that little pouch, which is not healthy for the patient at all. So that is one indication. The other would be rectal intussusception. Remember that intussusception is a telescoping of one section of the bowel on itself or on another portion. So the rectum actually telescopes into itself. That might be another reason a patient would have this ordered. And the third reason would be a prolapsed rectum. And a prolapsed rectum would be when the rectum actually comes outside of the body. You might have heard of patients having prolapsed bladders. Sometimes women can get prolapsed bladders after childbirth because the muscles are so weak that the bladder literally falls out. You can also have a prolapsed rectum, and that can happen to both males and females. If you look at 508, you will see this specialized equipment that typically they have like a commode on wheels. It's usually a box with a toilet seat, and then they have a red bag underneath because whatever the patient evacuates or gets rid of that barium, it goes into the red biohazard bag. After the exam, the covering on the toilet seat is removed, the toilet seat is cleaned, this is thrown away, the red bag is disposed of properly. But you can kind of see that this table is actually upright, and this slides right in because the most common position done for deficogram is the patient in a lateral position. Okay, so the patient is seated on the commode in a lateral position with the table upright, and the fluoro tower actually comes across the patient so that the radiologist can take images as the patient is having the evacuation and the rest phase of the deficogram or having that bowel movement. Now, this picture here is also on page 508. This is on 509, but lateral is the most common position that's taken. This is actually the contrast media that's used. You have a liquid contrast media that is taken orally. This is called Polabar. And the patient takes 2 cups of Polabar 2 hours prior to the exam. So that's ingested through the mouth. And the Anatrast, I know it looks like caulk in a caulk, and it really is, but before you panic, this does not go in the patient, okay? The part that goes in the patient is this tubing, and we fill this tubing right here, this D1 and D is full of contrast, the Anatrast, and so is the syringe. Okay, so this is reusable, just like caulk. You use caulk and then you put it away and then you use it again later. The Anatrast is the same way. It's multiple uses. You would fill this tubing right here and fill the syringe, and this is the only part that goes in the patient. The D1 would go in the patient's rectum. The radiologist would push the contrast into the rectum. And honestly, we asked the radiologist, why do we use an oral contrast and a rectal contrast? And they said that pretty much what happens is the two act like a magnet. They're drawn together, and then it gives a much better study when the Polabar comes down in that 2 hours prior to meet the Anatrast. The image is a lot better with both of these contrasts than with just one or the other. So the evacuative proctography, they show you that it's a 2-phase study. So you get images, you pretty much set the patient up. Let me go back. You set the patient up in a lateral position. You give them as much privacy as you can. You and the radiologist are likely all the way at the other end of the room with the monitor turned, and you probably would put some kind of sheet or something on here so the patient is actually blocked so that they're not super embarrassed to be able to, because once you have this Anatrast in there and the patient's already drank the Polabar prior to coming in, what you want to do is the radiologist will set up the fluoro tower so that they are focused on the rectum. Okay, and then you can see this one is labeled screening, this one says defecate, and this one says rest. So you actually, the radiologist is going to take images when they're starting to bear down to have a bowel movement, as they're actually passing the barium like a bowel movement, and the rest phase after they've already passed that. So bearing down like they're going to have a bowel movement, actually having the bowel movement come out, and then the rest phase after the fact. So this is barium. This is not fecal material, but you take images, or the radiologist takes images during these. And what they do is they measure the anorectal angle on the patient. Now that's, the radiologist takes that and measures the anorectal angle or the anorectal junction. It has to be demonstrated during this procedure, and it represents the alignment between the anus and the rectum that actually shifts between the strain and evacuation phase. So they measure that angle during the phases to determine if there are any abnormalities. All right, and most of the images, if any, that are taken, aside from this, would be done by the radiologist during fluoro as the patient's bearing down. It is possible that we take a lateral image after the fact to go along with that. Okay, and all of this is on page 508 and 509. And the last thing that we'll talk about, the other exam of the lower GI system, is actually a colostomy enema. Now, this is much more commonly performed than the deficogram. A lot of patients actually have colostomies, and this is on page 509. So a colostomy, when they talk about a colostomy barium enema, they tell you that the colostomy is a surgical formation of an artificial or surgical connection between two portions of the large intestine. So sometimes when there's disease or tumor or an inflammatory process, they'll actually take a section of the large intestine and they'll remove it, or they can alter it. And it says that once they do that, they'll usually bring the terminal end of the intestine to the anterior surface of the abdomen, where they make an artificial opening, and that opening is called a stoma. And what they'll do is have the intestine, the terminal portion of the intestine, will come through that opening, and the patient will actually not have normal bowel movements through the rectum, but they will actually empty the contents into a bag, a drainage bag, something similar to this, connected to the stoma. So instead of the patient having a normal bowel movement for this time frame, it actually dumps into the bag. Now, these colostomies can be temporary or they can be permanent, meaning it is possible for a patient to have a section of intestine removed and they bring the terminal section to the anterior surface. They allow the patient to heal. They allow time for everything to be situated. And it is possible that they go back in and they reconnect that section of intestine. That reconnection is termed an anastomosis. A-N-A-S-T-O-M-O-S-I-S. Anastomosis. That is the reconnection after a patient has had a colostomy. So that could be, if they have a temporary colostomy, eventually they will do an anastomosis. Now, how long is temporary? That really is up to the surgeon. I actually had a friend, still have her as a friend, but she had horrible Crohn's disease, and she had her entire large intestine removed. And she was very young when they did this, probably in her early 40s. What they did, the surgeon actually brought the terminal portion of her ileum, so the last section of her small intestine, he brought it to the anterior surface of her abdomen near her belly button, and he had her connected to a colostomy bag. It was temporary, but she had that colostomy bag for 18 months. After 18 months, when everything healed, he took the terminal portion of her ileum and he connected it to her rectum so that she could have normal bowel movements. Now, the problem is that she does not have any large intestine, so there's not that reabsorption of water and that compaction. So pretty much every time she eats, she has a bowel movement, and that bowel movement is very loose, but she still is able to have gotten rid of the bag and have a bowel movement. She can go into the restroom just like anybody else and have a bowel movement, even though it's loose, but it's way more normal than having this colostomy bag. Now, I will tell you that colostomy patients are typically mortified by the fact that they have a colostomy. There is a distinct odor that goes along with this colostomy bag, because no matter how clean you are and how hard you try, it's very hard to disguise the smell of feces. And it's not solid feces, this is liquid feces. And this bag is somewhat porous, so the smell is potent, to say the least. And they recognize it, and they're typically mortified. They're usually very apologetic for the fact that they have it. They apologize up and down for the smell, but you have to be very matter of fact and not allow them to feel embarrassed or feel bad about having this colostomy. You have to act like this is a normal everyday thing, and this is typically what you deal with on a daily basis. Okay. Some of the indications, I didn't mention that, for a patient having this would be to have proper healing of the section that was removed. It could be a possible obstruction that they're relieving, or they can test for leakage to perform a pre-surgical evaluation. So I can tell you that when my friend had her large intestine removed, before they performed the anastomosis, they basically tested both sections of it. They put a regular enema tip into her rectum. Now, remember, at this point, nothing was attached to that. So they used water-soluble iodinated contrast, and they injected it into the rectum to make sure that it was open or patent. And then they took the terminal portion of her ileum, and they put one of these colostomy tips in there, and they ran water-soluble iodinated contrast media through the terminal ileum to make sure that that was open or patent. Because the last thing a surgeon would want would be to reconnect that ileum to the rectum and then find out that somewhere there was a blockage and it wasn't going to work. So a lot of times we are doing these colostomy enemas to make sure patency or open, there's that the area that was surgically operated on is open and functioning. Okay, so you could do it before they have their anastomosis. You might do it right after they have the colostomy to make sure that everything is functioning and flowing as it should. But the biggest thing I would tell you with these patients is that you really, really have to be almost like a little cheerleader for them, because they are mortified to have this done. A lot of times these colostomies cause the patients to be recluse, to kind of hang out in their home, not want to come out, not want to interact with society because of the smell. Now, I have met a lot of patients that do a good job at keeping the odor down, but most of the time these patients tend to be elderly, and caregivers are elderly, like a little old husband and wife. So it's hard for them to clean these. There's typically a lot of accidents with these because of where they place the stoma. It's usually above the waistline of the pant, so that this bag hangs over the pant. And imagine the seal on this is good but not the greatest. So once this bag fills, either with liquid feces or with air, because the patient is still going to have flatus just like a normal patient, what happens is this seal can actually get, broken, and then they have an accident where they have this liquid fecal material leaks on their pants, leaks in their car, leaks on their clothing, and then the smell is just, I don't know how to describe it other than once you smell it, you don't typically forget that. There's certain smells in our field that you never forget. Burning flesh, a GI bleed, and a colostomy are just some, to name a few. Okay, so you have to have the best possible patient care and bedside manner that you could ever have for a colostomy patient. I can tell you that my grandfather had a colostomy because he had colon cancer. They actually took out the section of colon. My grandfather was in his late 60s, very independent, still went to work every day, up before the sun, in bed when the sun went down. was a farmer, worked at a facility that made airplanes. I mean, just very, very independent, very gung-ho guy. When he had the surgery and ended up with this colostomy, I truly believe that is what caused his death, not the colon cancer. He was absolutely mortified to have this. He didn't want anyone helping him. He didn't want anyone seeing it. He wouldn't allow anybody in to assist him. He would let like the home health nurse come in occasionally, but it just mentally did him in that he had to have this. And I believe with everything in me that the fact that he had to alter his life and then have this colostomy, that was much more deadly to him than the colon cancer that he had. So again, I have a special place when patients have these. I try really hard to make sure that they know that, you know, it's not a big deal. I deal with this all the time. I don't say those words, but I try and let my actions portray that this is no problem. I'm happy to help them, and it's just another day at work for me. Even though honestly smells, I do not do well with smells. These are some of the hardest for me to deal with, but they would never know that by my face or my actions. Never would they know that, because I would never do that to them. So, all right, so that is a colostomy kit. That is on page 510. And then you would actually place this tip into, you or the radiologist would put this tip into the section of bowel that you're looking at, whatever's coming out. Like this is actually on the patient, this flare disc, and this opening can be made bigger to allow more of the intestine to come out. And then it's usually stitched so that the hole is smaller on the patient's actual abdomen, because you don't want that section of intestine slipping back into the patient. So this stays on the patient. The little piece of intestine comes out through that hole. You would put the enema tip into that section of bowel, and then you or the radiologist will put the contrast media in and take pictures. Once you're done, you take that tip out. You would clean this area off, and then this bag right here, this white ring, attaches to this flesh-colored ring right there. Once you're done with any of these, whether it's a double contrast study, your evacuative proctography or your deficogram, or the colostomy enema, what you have to tell the patient, as with any fluoro procedure, is that they need to drink 8 to 10 glasses of water in addition to what they normally drink until their stool returns to a normal color. And I just added, please do not advise your patient to take any laxatives or to increase their fiber. If they have those kinds of questions for you, make sure you direct them back towards the doctor that ordered this exam.